Bismillahir Rahmanir Rahim. Assalamu alaikum, ladies and gentlemen, chairpersons of the session. I would like to thank the organizers for the invitation. I hope you've sent me in a correct batting order and not as a night watchman. And if you have, then you would have had two fantastic talks by two eminent hepatologists and great. It's a shame that I cannot be there with you physically. I am here in Southampton, which is a city located along the south coast of England, an hour's drive away from London. So if you happen to be around this neck of woods and we are out of COVID restriction, then you're very welcome to come and visit us. So my remit for this session is to discuss validated risk stratification systems, talk about a key prognostic factor in patients with cirrhosis, which is quite close to my heart, with a view to optimize our patients for a safe outcome of surgery. And when we are discussing all this, our patient is at the center stage. You're all well aware of the different stages of fibrosis, which lead to the development of cirrhosis. Once a patient has developed cirrhosis, there are patients out there in the community who we don't know really about. So who do we know? Or in other words, which is a single best prognostic factor in patients with cirrhosis? So let's just park this thought for a minute. And let me just take you through a couple of cases. First is of a 28-year-old lady who had pan-ulcerative colitis. She was on 5-ASA. She also had quite an advanced PSC with portal hypertension, as you would see from the images on the right side of the screen. She had already been accepted on liver transplant list. She presented with acute severe colitis, did not respond to steroids or rescue infliximab. Her stool was not as happy as you see here. However, the cultures for common pathogens, C. difficile, CMV were all negative. On day 3, her CRP was still elevated and her bilirubin was falling. Question was it safe to proceed with colectomy? And if not, were there any other measures to reduce her portal hypertension? So second case was more straightforward. 56-year-old man with colorectal cancer diagnosed on bowel cancer screening program. He had risk factors for metabolic syndrome. Staging CT demonstrated METs, which were deemed resectable. There was a concern that he may have had an underlying advanced hepatic fibrosis stroke cirrhosis. The liver edge was irregular, spleen was borderline enlarged. There were venous collaterals on scan, and his platelet count was also borderline low. So clearly, surgeons were concerned that there was a risk of potential hepatic decompensation post-surgery. Before we discuss further about our cases, let's talk about the things that we do well or should do well. Most of these things have already been covered, but it's important to manage patients' deteriorations and complications actively. So this document that you see on the right side of the screen is a decompensated cirrhosis care bundle produced by Basel and BSG. It is very useful for junior doctors and non-hepatologists when they're managing patients in first 24 hours after their presentation with hepatic decompensation. So I would strongly encourage you to consider using this if you're not already using it. We want to address our patients' nutrition needs, prescribe exercise or rehabilitation program, and address all other needs, including their psychosocial support. We work in multidisciplinary team, therefore we have to ensure that our surgeons are appraised if a patient is admitted with deterioration whilst waiting for a surgery. The validated risk stratification system or tools are common in our clinical practice, including Child-Pugh score, MELD, and UCALD in UK. Mayo postoperative mortality risk score is an online tool, easily accessible and very useful if you're asked a question about a surgical colleague about risk of deterioration, mortality, morbidity in your patients who are being considered for a surgical intervention. Important thing here is that as per AGA guidance, there is no single definitive risk stratification system to determine operative risks in all patients with cirrhosis, and AGA therefore recommends using multiple methods simultaneously. A recommended approach for pre-op risk assessment, we want to look at the type of surgery that is being considered, if it's emergency or elective. In cases of an emergency, are there any obvious contraindication? If so, then surgery is contraindicated. If there are none, then we could support our surgical colleagues in planning and proceeding for surgery. In cases of elective surgery, we still have to ask and answer the question about the evidence of underlying cirrhosis. And if there is none, then patient can again be supported to proceed for surgery. In cases where there is evidence of cirrhosis, we should try to stratify them using validated tools into three common categories as a traffic light system, which I'll discuss a little bit further in the next slide. So if a patient has a MELD of less than 10 or child class A, then they can proceed to the planned surgery. And those with MELD score is more than 16 or their child class C, then we should consider alternative options if available. This is a group of patients we should also ask if they've been considered for transplant assessment or not. The group in the middle in a gray zone or a yellow zone is the one with child class B or MELD between 10 and 15. In this group of the patient, we do have to ask the question about presence or absence of portal hypertension. If portal hypertension, clinically significant portal hypertension is a possibility, then we have to consider measures to reduce portal hypertension, including tips. In those where there is no evidence of clinically significant portal hypertension, then patient can proceed to surgery with careful post-op monitoring. So I'll spend a few minutes on portal hypertension, which is single best prognostic factor in liver disease. We know that it results from increased resistance to hepatic sinusoids to blood flow, and it will increase the risk of esophageal gastric varices, portal hypertensive gastropathy, ascites, hepatorenal syndrome, etc. Now, measurement of portal hypertension has been useful in determining the stage, progression, and prognosis of cirrhosis. The way we measure it, we use hepatic venous port pressure gradient, which I will discuss in next slide. This has been shown to predict the likelihood of clinical decompensation in patients with compensated cirrhosis, as well as predicting the risk of developing hepatocellular cancer. So it is the single best prognostic factor. But question is, does HVPG accurately reflects the degree of portal hypertension? Because portal hypertension is what guides the medical and surgical treatment. The classification according to the site of vascular obstruction, post-sinusoidal, post-hepatic, post-sinusoidal, intrahepatic post-sinusoidal, or sinusoidal, which is the commonest cause, intrahepatic pre-sinusoidal, or pre-hepatic pre-sinusoidal. Whatever the site of obstruction is, there is a relevance and there's an importance, again, which we will discuss in the coming slide, but we still have to bear in mind the other comorbidities and other complications, because this is what determines the ultimate outcome. And this is quite relevant in the liver transplant world. As I was mentioning about the role of HVPG in the differential diagnosis of portal hypertension, because you would all have come across patients with pre-hepatic portal hypertension where wedge and the free pressures will be normal, therefore HVPG will be normal. Or those where they, for example, patients with heart failure where the wedge and free hepatic vein pressures are increased and therefore the HVPG is normal. So how does it help in a clinical practice? There is plenty of data out there looking at the HVPG values and associated risks. Now, since our focus today is surgery in patients with cirrhosis, therefore we believe that higher the HVPG, higher the risk. Now, that statement unfortunately does not apply doesn't entirely apply to the group of patients who have HCC and undergoing resection, because this data, although quite old, reported decompensation after surgery in patients with hepatomas, even when the pressure HVPG was not elevated. The question we ask here is, was HVPG accurately reflecting portal hypertension in this group of patients? So this prospective study looked at the prognostic value of HVPG in cirrhosis patients undergoing extrahepatic surgery and concluded that HVPG, ASA class, and high-risk surgery were prognostic factors of 1-year mortality in cirrhosis patients undergoing elective extrahepatic surgery. So HVPG values of more than 16, especially more than 20, were associated with high risk of post-surgical mortality. So let's discuss how we measure it in clinical practice. We diagnose it by percutaneous transjugular pressure measurement. Now, this method, as we all know, is invasive. It requires ionizing radiation, IV contrast, and yet only gives us an indirect measurement. It is, as you all know, is performed by placing a catheter into the right jugular vein, advancing into the hepatic vein under fluoroscopic guidance, and once we are in the hepatic vein, the pressure can be measured directly, which is what we call free hepatic venous pressure. The portal vein pressure, however, is usually determined indirectly from the wedge hepatic venous pressure, and that the gradient between free and wedged hepatic pressure is termed as hepatic venous pressure gradient, which reflects the degree of portal hypertension in all forms of portal hypertension. Now, the importance here is that this estimation can be inaccurate in cases of prehepatic portal hypertension, such as portal vein thrombosis, where we may need Doppler ultrasound scan. In addition, in patients with hepatic pre-sinusoidal portal hypertension, such as myeloproliferative disorder, we can end up having an inaccurate HVPG. So what do we have available these days that can provide us a direct measurement? So with using EUS guided approach, we can pass a 25G needle into the hepatic vein, measure a direct pressure, then into the portal vein, measuring direct pressure, and then actually subtracting the two values and getting an accurate reading of portal pressure. There is plenty of data out there supporting the utility of this tool. I know HVPG is the gold standard as it stands. So this study is to reassure us all that there's no statistical difference in the pressure gradient and procedure time between EUS portal pressure gradient and other routes of measuring portal gradient. Now, EUS guided approach is not widely available. There is a learning curve, and I appreciate not all hepatologists would agree with a relatively invasive approach. Especially in a country like ours, we have to rely on the non-invasive methods. Now, this review by Gashiet Tsao and group, published recently in Gastroenterology, compared the existing paradigm where we looked at where we asked for upper GI endoscopy, look for the varices, and decide on presence or absence of clinically significant portal hypertension. A suggested new paradigm of focusing on platelet count, liver stiffness obtained via transient elastography, and taking these into account, we could decide on the presence or absence of clinical significant portal hypertension and guide treatment accordingly, which is economical, practical, and I guess is quite a pragmatic approach. So let's talk about actual surgery in patients with cirrhosis. So we have to ask the question, what type of surgery is being considered, anatomical site, and timing of the surgery, because there's a lot of variation between elective and emergency surgery, hepatic and extrahepatic surgery. There are certain high-risk procedures such as HPB, intra-abdominal, cardiothoracic surgeries. Pathology is always a dynamic process. Likewise, surgical risk is continuous, and there are no absolute cutoff values for excluding patients with cirrhosis from surgical procedures. We therefore have to weigh the potential benefit and risks working with other colleagues in MDTs. And if surgery is deemed necessary or appropriate, then it should be done in centers with expertise of managing patients with portal hypertension. This is also important when we are considering whether it's hepatic or extrahepatic surgery. We know or have seen patients who've been diagnosed inappropriately as cholecystitis because of the edema of the gallbladder wall. Now, cholecystectomy itself, there's a significant risk of complication in patient with cirrhosis, and therefore it should be avoided in patient with confirmed diagnosis of cirrhosis. If it, as I said, if it's needed, then has to be done in a center with expertise. The same applies to abdominal hernia surgery, except for incarceration that cannot be manually reduced, or suspected strangulation with bowel ischemia or gangrene. The surgery should be avoided in patients with cirrhosis and ascites, unless the ascites can be completely controlled. As you would all appreciate that the wound dehiscence, peritonitis, and poor outcome frequently occurs when ascites recurs after hernia surgery. The special case of primary liver resection in patients with cirrhosis, usually for malignancy, is well studied, thoroughly studied than other general surgical procedures, and data does support safety profile of segmental liver resections in patients without clinically significant portal hypertension. So based on our understanding, obviously the transplantation remains on back of our minds. If the patient does decompensate after surgery, they may become a candidate for transplantation. Unfortunately, there isn't a clear cutoff when we look at the MELD score for selecting patients for liver transplant evaluation before elective surgery is considered. The AGA recommends that preoperative liver transplant evaluation when predicted 3-month mortality rate is more than 15%, or when the MELD score is more than 15. Another important type of surgery to discuss is bariatric surgery. This study from USA, where they identified the patient, so it was a national registry sample between 1998 and 2007. They had 3 groups of patients: decompensated cirrhosis, compensated cirrhosis, and those who didn't have cirrhosis. Decompensated cirrhosis were identified patients who had diagnosis code of ascites of varices. Limited number in that group, but you would not be surprised that the in-hospital mortality and length of stay was higher in patients with decompensated cirrhosis compared to those who did not have cirrhosis or had a compensated cirrhosis. I don't want to undermine the importance of bariatric surgery. I would therefore like to share this multi-center retrospective observation study performed by the obesity group of Spanish Society of Endocrinology, where you would see that although there was no significant impact on the MELD score, but when we looked at all the metabolic risk factors, across the board, there was a significant there was a positive impact of bariatric surgery. So they concluded that the bariatric surgery in selected patients with liver cirrhosis has metabolic benefits that could potentially have a positive impact on liver prognosis. The AGA guidance is that centers with expertise in surgery in cirrhosis patient may perform bariatric surgery as long as patient does not have a clinically significant portal hypertension. And in highly selected patient with obesity and decompensated cirrhosis undergoing liver transplantation, a sleeve gastrectomy could be performed at the time of transplantation. So in the remaining few seconds, let's briefly discuss the measures to reduce portal hypertension, mainly pre-operative tips. The benefits, as you all know, of prophylactic tips are restricted to bleeding, and physiological changes can take weeks. We offer it mostly to patients with Child-Pugh A or early B, and not in those who have Child-Pugh C. The AG recommendation is that absolute benefit of tips over conservative managements are not well established, but it can be offered to patients, has to be done by case-to-case basis. This is another huge topic, but it's important to briefly touch upon it, as there's a significant risk of bleeding intraoperatively, which is what our surgical colleagues are concerned about. Important thing to bear in mind is that there are no established preoperative safety threshold for INR, and therefore AGA does not recommend protocol transfusion to target INR. We should avoid needless transfusions or volume overload to exacerbate portal hypertension, which can make bleeding worse. Post-op care again requires collaborative working with surgical colleagues, ensuring regular monitoring and avoiding of fluid overload to exacerbate portal hypertension. So this has already been covered, and just in the interest of time, I'll skip past this. So in conclusion, we have to make best use of existing validated risk stratification tools, work collaboratively with our surgical colleagues, and try to restrict surgery in patients with cirrhosis in center with expertise. So thank you very much for listening, and I look forward to your question and answer session.
Assalamu alaikum. Thank you, Nadeem. Excellent talk. Now the house is open for question and answer.